Good morning, good afternoon, everyone, esteemed colleagues. My name is Poonam Patel. I'm here to present a case on euglycemic diabetic ketoacidosis, or EDKA, in type 1 diabetes mellitus. This case report highlights a clinically significant yet often overlooked variant of diabetic ketoacidosis. So our aim is to elucidate the underlying mechanism, associated risk factors, and clinical implications, which poses a diagnostic challenge due to its atypical presentation. So the subject of our case is a 22-year-old female with a past medical history significant for insulin-dependent type 1 diabetes mellitus, recurrent hospitalizations for DKA, diabetic neuropathy, and medication noncompliance. So upon admission, her chief complaint included severe lower abdominal pain. She rated 9 out of 10 with radiation to the back. Additional symptoms included prolonged constipation, fatigue, nausea, intermittent vomiting, headaches, dyspnea on exertion, decreased appetite. She also reported that she exhausted all her supply of insulin 2 days prior to presentation to the ED. Physical exam was fairly unremarkable, except for mild generalized tenderness on abdominal palpation. For diagnostic, the ED did a comprehensive workup, including UDS, beta-HCG, CT abdomen, pelvis, which were all unremarkable. Her blood glucose level was recorded at 121, which is notably lower than the threshold for hyperglycemia in DKA. Despite this, she exhibited profound metabolic acidosis evidenced by the arterial pH of 7.21, serum bicarb of 9, and an anion gap of around 11 or 12. Moderate ketonemia was also confirmed with ketones detected in both urine and in blood. Electrolytes abnormalities were also apparent, including hypokalemia with a potassium level of 2.9, which is particularly concerning given its potential to exacerbate cardiac and neuromuscular complications. These findings aligned with the diagnostic criteria for EDKA, characterized by significant acidosis and ketonemia in an absence of severe hyperglycemia. So EDKA is a rare yet clinically significant subset of diabetic ketoacidosis, accounting for approximately 2.6 to 3.2% of all the diabetic ketoacidosis cases. The hallmark of this condition is the presence of that ketoacidosis with a normal glycemia or only mild hyperglycemia. The pathophysiology for the EDKA is very complex. It occurs when due to a carbohydrate deficit leading to reduced serum insulin and increased counterregulatory hormones such as glucagon, epinephrine, and cortisol. So this imbalance causes a high glucagon insulin ratio leading to lipolysis and ketoacidosis. Ketone production involves the acidoacetic acid, beta-hydroxybutyric acid, and acetone, which results in that anion gap metabolic acidosis, which then triggers the respiratory compensation and the sensation of dyspnea, as well as nausea, anorexia, and vomiting, which our patient had. Volume depletion resulting from decreased oral intake, vomiting, osmotic diuresis from glucosuria. It further exacerbates the elevation of that counterregulatory hormones, and that cycle just keeps repeating. There are several risk factors that have been identified, including prolonged fasting, pancreatitis, pregnancy, alcohol use. A particularly noteworthy risk factor is the use of sodium glucose cotransporter 2 inhibitors. These agents are now employed in the management of diabetes very much so in day-to-day, and it facilitates the renal excretion, thereby reducing the blood glucose level, but potentially precipitating ketoacidosis, especially in type 2 diabetes. For treatment, the management of EDKA requires a very tailored approach, which is distinct from the guideline approach of traditional diabetic ketoacidosis. So in this case, we initiated an aggressive fluid resuscitation as per ADA guidelines with a half normal saline, D5, and K riders to address both the dehydration and the electrolyte imbalance. So insulin therapy was commenced once the potassium level safely was about 3.3. We did a close monitoring of biochemical parameters such as BMPs and arterial blood gases, which was essential to guide this therapy. And the primary objective for us for the treatment was to achieve a serum bicarb greater than 16, as that patient did not have an anion gap for this specific patient. So we used just bicarb levels and to see if the metabolic acidosis will resolve. Following 48 hours of management in ICU, the patient's bicarb level stabilized. She had clinical improvement, and then we permitting this transition to sub-Q insulin. She was subsequently discharged with comprehensive education on medication adherence, emphasis on prevention of DKA or EDKA, but notably there were no subsequent admissions for EDKA. She had multiple admissions for DKA, but none of them were euglycemic. So this case highlights the critical importance of recognizing and managing euglycemic DKA, particularly in patients with diabetes and patients who are on SGLT2s. The atypical presentation necessitates a high index of suspicion for this, because if we do not recognize it promptly, then we can delay the treatment and can lead to adverse outcomes. Attention from our medical community. The rising use of this novel pharmaceutical agents such as like SGLT2s, I think it underscores the urgency for heightened clinical vigilance and robust evidence-based medicine and guideline, because we do not have EDKA guidelines currently. So by advancing our understanding of DKA, we can improve the diagnostic accuracy, we can come up with therapeutic intervention, and ultimately get better patient prognosis. Thank you so much for your attention. If you guys have any questions,